infective endocarditis. And please stop me if not clear, if I'm not clear at any point. So let's start with this case. It's a real case, and by the end of this presentation, let's take a decision together on this patient. She is 46, female, treated for several weeks as a case of documented MRSA infective endocarditis in another hospital. The patient is non-ambulatory because of rheumatoid arthritis. She is grossly neurologically intact, but debilitated because of rheumatoid arthritis. She does have bed sores. She is not in active heart failure. And her CT brain showed showers in the brain, no hemorrhage, and no major stroke. Her septic profile is reasonable, white cell count 12, and her cultures, blood cultures were negative on this admission. This is her echocardiography showing moderate mitral regurgitations. Other valves do not have significant pathology. There is a vegetation on the anterior mitral valve leaflet, which is oscillating. The size of that vegetation is nearly 2 centimeters. And this echo is done like maybe 4 weeks after the initial diagnosis. Decisions. We'll come for decisions at the end of the presentation. We'll go over the tricuspid valve. This on the upper panel, you see the common lesions you see in classical infective endocarditis, oscillants, nose, where lesions and splinter hemorrhage. This is just a general look at patients who have classical infective endocarditis. We'll go over the definitions, pathology types, diagnosis, surgical indications, and surgical principles. Infective endocarditis is a disease of the endocardial surface of the heart. But when you say endocarditis, it implies as if the entire endocardium is involved, like cystitis and endometritis. We know this is not the case. The infection of endocarditis typically involves the valves focally or multifocally, whether being native or prosthetic valve, or an implanted cardiac device. It can be acute if the symptoms present within days up to 6 weeks, subacute if the symptoms present beyond 6 weeks up to 3 months. Beyond 3 months, people call it a chronic infective endocarditis. Prosthetic valve endocarditis is categorized as early when it is within 2 months and late when it is beyond 2 months. And intravenous drug abuse endocarditis is discussed separately by some. It is not uncommon. 15 cases per 100,000 are affected by affective endocarditis. It's important for surgeons because even with very good antibiotic therapy, 1/3 of patients of infective endocarditis in the contemporary era still require surgery. Most of these patients have risk factors for developing infective endocarditis, having a pre-existing degenerative valve disease, rheumatic heart disease, prosthetic valves, indwelling catheters, implanted cardiac devices, and there are too many of them nowadays, diabetes, immunosuppression, and congenital heart disease. The microbiology, there is regional variation in the most common organisms causing infective endocarditis. Thus, most of the place staph is a leading cause of infective endocarditis, followed by a very dense group of streptococci. The hallmark of these pathogens that cause infective endocarditis is their ability to form what is called a biofilm. A biofilm is an extracellular matrix that protects these bacteria from the host defenses and invasion by the antibiotics. All bacteria that cause endocarditis, almost all, staph, strep, enterococci, all have those abilities that make them very virulent organisms. So the surgery actually destructs physically these biofilms, vegetations, anything that covers these bacteria and make the antibiotics work. The diagnosis of infective endocarditis, classically people use the Duke's criteria. It has a pretty good sensitivity and specificity for clinical endocarditis. It relies on cultures and imaging findings. If you have 2 major or 1 major and 3 minor or 5 minor, it is a definite endocarditis. Anything else is possible or no endocarditis. The sensitivity, the imaging of the coronary stone. So cultures, we know we take cultures, and then you need the imaging. Imaging for surgeons, you cannot make decisions on endocarditis if you don't have a good image and mental picture of the lesions. So imaging is cornerstone for diagnosis, especially from surgical perspective. Transthoracic echo is people start with. If the pathology you see on transthoracic, it means that the pathology is gross. It has specificity is less than 50%, sensitivity is less than 50%. The transesophageal is an important tool in diagnosing infective endocarditis pathology. It has double the sensitivity and specificity of the transthoracic echo. And as young surgeons, I think you will get more and more intracardiac echocardiography images in your future practice. It takes images from close to the heart, from within the heart. If you have it on the right side through the venous axis, which is less risky, you can still get very close images closer than the TE on the left side of the heart also. Multi-slice CT scan is important in diagnosing satellite lesions. MRI is used for the brain. And PET scan is very good tool to increase the sensitivity and specificity of Duke's technique, especially in catheter-related and device-related infective endocarditis. Mycotic aneurysms can only be diagnosed by cerebral angiography, not by CT scan or MRI. So is there any non-infective endocarditis, non-bacterial? Yes. So we are discussing infective, but we need to know that there is a non-infective non-bacterial endocarditis, and it's not very infrequent. You get confused. You presented with a case having a valvular lesions and equivocal cultures. You have vegetations, you have valvular lesions, and diagnosed as infective endocarditis. The objective of treatment of these cases is different. We need to know that there is something that confuses the picture of infective endocarditis, including marantic thrombotic endocarditis. These patients harbor malignancy and hypercoagulable states. So always try to know more about any case presented for infective endocarditis. Liebman-Sachs endocarditis, you have flat vegetation on both sides of valves. Again, it can cause valve dysfunction, and it can have similar lesions like infective endocarditis in the form of vegetation. If you treat it the same like infective endocarditis, you might not do the optimum for the patient. Of course, endocarditis can be a part of the pancreatitis caused by rheumatic fever. And we know that serotonin also causes endocarditis, especially on the right side, if there is no right to left shunt. It will be isolated on the right side. Culture negative infective endocarditis is very much can be confused with these non-infected non-bacterial infective endocarditis. Anybody can ask you if in exam, whenever you go for culture negative endocarditis, you will be asked what is the reason. We know the HASIC group. Somebody might ask you what are the HASIC organisms. And of course, you should know antibiotic use is the most common cause of culture negative infective endocarditis. So one third of patients of infective endocarditis require surgery in spite of antibiotic use. We know that bacteria have the enzymes, they destroy the tissues and they cause valve dysfunction, they cause paravalvular diseases, fistula, a lot of things. Once the valve becomes leaky, it will not become competent again if it has become so because of infective endocarditis. And disintegrated tissue leading to fistulation or any sort of pathology, those will not regrow. I've quoted this from an ATS presentation. There is a significant risk for these patients. If you do surgery too late, they might embolize. And if you do it too early, if they have hemorrhage again, the risk is increased. Objective of surgery in infective endocarditis is elimination of infection and treatment of the complications. This slide I've taken from Mayo Clinic. It's a recent presentation in Mayo Clinic. It describes precisely the indications for surgery in infective endocarditis. Number one is always the class 1, heart failure. If endocarditis leading to valve dysfunction or intracardiac fistula causing pulmonary edema or cardiogenic shock, these patients almost always need to go right away to surgery once you marinate them with antibiotics. They have enough antibiotics in their circulation, then you take them right away. These are the earliest cases that you take for surgery. If you have persistent infection, this is less urgent, not like heart failure, because you need time to prove that it is persistent infection. You need to give them the appropriate antibiotics for a good time, at least a week. So enlarging vegetations or persistent bacteremia despite appropriate antibiotic therapy is a class 1 for surgery. Complications of infection, local uncontrolled infection resulting in abscesses, especially related to the aortic root, heart block, or penetrating lesions in the form of fistulae or pseudoaneurysms. Prevention of embolism if you have mobile vegetation more than 10 millimeters, especially when involving the anterior mitral leaflet in the setting of a previous embolic episode. This is a very nice algorithm. Again, algorithm help decision making. It's again from Mayo Clinic in May 2020. So if you have a case of endocarditis, first question you ask yourself, does he have a major stroke, embolic or hemorrhage? If he has that, a major stroke, then you delay surgical intervention for at least 4 weeks. So this is what they do in Mayo Clinic. If he doesn't have a major stroke, then you look for class 1 indications for intervention. The same one that were mentioned in the indications of surgery: valve dysfunction leading to congestive heart failure, resistant organisms like Staph aureus or fungi, heart block, abscesses, persistent infection, and relapsing prosthetic valve endocarditis. If these are present, indications for early surgery are there. If these are not present, then you look for class 2 indications, which are large mobile vegetations or recurrent emboli and persistent vegetation despite appropriate antibiotic therapy. If that's present, consider early surgery as a class 2. If that's not existing, then just continue antibiotic therapy. For surgical indications, consider re-imaging for the patient. So this is a summary of class 1 indication and class 2 indications. The most important class 1 indication is the heart failure resulting from valvular dysfunction. Timing of surgery. Timing of surgery is really a hurdle in decision making, especially if you have CVA. Not too much randomized trial. This is one of the rare randomized trial in this subject, RCT from South Korea, to 2012 in the New England Journal. So they have randomized patients for early surgery within 48 hours versus conventional. Their primary outcome was death plus embolic phenomena within 6 weeks. The result was that early surgery had a significant reduction in the composite endpoint. The limitation of that randomized trial was it was a small group, 40 patients per group, and most of the cases of endocarditis were caused by Streptococcus, which is low virulent organisms. Mycotic aneurysms, if they are present, they are detected by cerebral angiography. You should be suspecting them. They are present in a vast majority of cases of infective endocarditis. They carry a very high mortality of 30% if they are ruptured, and 80% if they are ruptured. This is an important slide, the principles of reconstructive surgery in infective endocarditis. If you are doing an infective endocarditis, especially the prosthetic valve endocarditis in the aortic root, you should have a very good plan for myocardial protection. We know the cardioplegia delivery is antegrade and retrograde. In a reduced situation, if you have a prosthetic valve, sometimes if you you have a fistula or regurgitant valve, you know that antegrade cardioplegia doesn't work. If you don't place a retrograde cardioplegia in these patients and rely on quickly opening the ascending aorta and delivering ostial cardioplegia quickly, you might be disappointed because in the presence of vegetation or prosthesis, you might fail to find immediately the ostia of the coronary arteries. So have plans for very good myocardial protection, even if you have to go to deep hypothermia, if you fail retrograde and you're struggling with aortic root cardioplegia. Adequate debridement. Debridement is a term that looks easy, but when you come to life, it requires a lot of experience and skills. So you debride. Debride means you remove the dead tissue. There is an obviously devitalized tissue that you can remove. And there is the questionable tissues that might have to be removed or left behind. So too much excisions will lead to problems because it's not cancer surgery whereby you do wide excision. The cardiac tissues are precious. You need to keep them if they are not dead or devitalized. Reconstructive become difficult when you do overzealous debridement. So what you can do is obviously dead tissues, usually by forceps, you can remove them like vegetation. In a questionable type of tissue, if the tissues hold your needle and you pull on the sutures, they don't cut through, most likely, of course, with certain force, not forcibly. If they hold the sutures, most likely they are okay to leave behind. Leaving behind infective tissue is also not good. It will risk recurrence of infective endocarditis. So debridement should be done carefully, not overzealous, yet not leaving behind any infected tissue. And the third principle is when you go to the surgery for reconstruction, you don't go with a single mindset of reconstructive procedures. Let's say, I will go in and do this patch for this region. This might not be true. So be free-minded because you don't know how much you remove. It could be less than what you expect. It could be more than what you expect. So have a broad spectrum of skills in terms of how to reconstruct what you remove. The autologous pericardium is your friend, resistant to infection, available, cheap, and no issues with that. Technical issues, principles, knowledge of anatomy is very important. Detailed knowledge of anatomy, because anatomy will not be the same after debridement and infection. So any lesion that starts on the left side, which is high pressure, and or ends in the left side, if infection is the right side, ends in the left side, it should be addressed from the left side. So fistulation, aneurysm, pseudoaneurysm should always be addressed from the high pressure side. This is an important principle. Otherwise, it will recur. And when you're doing mitral and tricuspid reconstruction, make sure you see with your eyes that you have restored endocardial, the ventricular endocardium to the atrial endocardium. Because any gap here will lead to catastrophic consequences. And in terms of aortic root reconstruction, make sure you restore the endocardial to endothelial continuity. Endocardium of the left ventricle to the endothelium of the ascending aorta, or whatever prosthetic material you have placed. This should be watertight and clearly seen without any gaps. Sutures should be placed on healthy tissues, of course. Any tissue that doesn't hold the sutures should better be removed.
Nadir, if I may just interrupt you for a second. The first point, I'm not sure I really understand it. The lesions that start on the or end on the left side should be addressed from the left side. What do you mean by that statement?
So if you have a fistula from aortic root to the right atrium, it would be easy to address from right atrium, right? But this is not the right thing to do. So you have to go to the aortic root and from the aortic root, because that's just a feeding flow. So if you close it from the right atrium, you'll just cause pseudoaneurysm outside the atrium.
I see, yes.
So any defect in the left side, high pressure side, should be repaired, whether it's fistulating or causing a pseudoaneurysm. And then always consider pacemaking backup, either permanent pericardial, especially dealing with the tricuspid and aortic root pathologies, endocarditis. Have a backup for pacing. Make sure in your room you have a functioning pacing cable and pacing device. And also for long-term pacing, you should have a clear plan. Time of surgery in a stroke, I will omit that. This is a case, one of the difficult cases, 32 years old female, had previous mitral valve replacement, presented with cachexia and established Staph aureus infective endocarditis. She had severe mitral paravalvular leak as a result of infective endocarditis. And she also had severe native aortic valve stenosis. And there was a complete disruption of aortomitral continuity. Here is the echo of that patient. Anybody can read? Just briefly.
This is long axis for external view showing, I will go to the positive finding, showing very large vegetation or thrombus and anterior and as well in the posterior mitral leaflet. And there is discontinuation between the aortic valve and the mitral with its large cavitation. The aortic valve here, it seems, I cannot judge, I need color or flow, but it seems there is no vegetation on it. And her ejection fraction, I need other view to be sure, but it's around 40-45.
So, yeah, excellent, Hussein. I have interruption on the, hello?
Yeah, yes, Nadir with you.
Just share screen again, kindly, Dr. Nadir.
I'm sorry. Because, this echo is presented just to show you the aortomitral continuity when it is disrupted, how it looks like, and I don't know why this is good. Did it come? Okay, the screen is back.
Yes.
Yes.
Good. So thank you, Hassan. This is a nice description for the echo. So you have an aortic stenosis, believe the report, and you have a mitral prosthesis in place, and you have vegetations on the mitral valve, and you have an aortomitral discontinuity. Okay. So what do you think of the orientation of the mitral valve, mitral prosthesis? Hello?
Seems rocking. It seems there is a rocking of the prosthesis, especially in the posterior aspect.
Yes, it is rocking and quite unstable, totally connected the water from mitral. And the mitral is facing, not the ventricle, it's facing the
LVOT.
LVOT, exactly. So how can you do reconstruction for this patient?
Commando procedure. Most likely she will need a large area of debridement and resection of the aortomitral curtain and creating new skeleton of the heart. Then you will put a new valve for her.
Yes. So the diagnostic is a complicated prosthetic valve endocarditis of the mitral prosthesis with native aortic valve stenosis and complete disruption of the aortomitral continuity. The sepsis was relatively under control with antibiotics. But these lesions will not heal. We have an aortic stenosis, we have vegetation, so the infection will come back as soon as we stop antibiotics. And the mitral prosthesis will get stuck and infection will stay on this prosthesis. So surgery is indicated based on this. And the surgery is quite huge and it's a real situation. So this is something that we have not published, but I'm not showing you the technique. That you should be versatile in terms of designing what you do in these cases. So what we did in this case, we removed the mitral prosthesis, and you know the aortic valve and the mitral valve are not at the same level. So you have a room to put a double set of pledged sutures on the annulus of any one of them, one on top of the other. Because we thought doing a commando in this case, the entry in this patient was very difficult. The reduced sternotomy was quite tough. So we thought we should do something else. So we removed the prosthesis of the mitral and the aortic, and we have now this gap in between them, how to fix it permanently, strongly, and make the mitral and aortic stuck together. So we put a set of sutures that are used for the aortic valve replacement in the mitral annulus on top of the mitral valve sutures. And that way we replace both valves and obliterated the cavity. It's easier, less destructive, and less labor than the commando procedure. And this is
one is a patch, doctor, or the valve itself? In the drawing, the circle you are making, this is the
mitral. Just to make it simple, the circle. This is a mitral valve. This is it's like a native, but it's a prosthesis. I've made drawing myself just to make it simple for explanation, so that you can take the pledged sutures of the aortic valve on the mitral side and go through that cavity in between the two valves to obliterate it and exit the suture through the aortic annulus. And those sutures are used to fix the aortic valve. Is this clear or?
Yes, thank you.
So you can also put a couple of sutures on the opposite side from the aortic annulus. You go through that cavity and come through the mitral annulus for the sutures of the mitral valve. Actually, that's what we did. And it worked. It saved our life. And this is a picture of the patient 3 years after. We have a new prosthesis, mitral, and a new aortic prosthesis. So another technique that, yeah.
Dr. Nazeer, so no patch. There was no patch. The mitral.
No patch. No patch. Yeah, we just remove the aortic valve natives, and so now you don't have a mitral prosthesis. Remove this annulus, debride it clean, and remove the aortic prosthesis. The aortic prosthesis clean is this. So there is a clean area to put your sutures, and unfortunately we have the gap between the two valves. So you place, like doing normal mitral valve replacement, you place your sutures, and opposite to the aortic valve, you place another set of sutures on top of those of the mitral and take them through that cavity and enter the aortic route. Through the annulus, you exit the sutures. And those are used to protect part of the mitral aortic valve prosthesis.
Just for me, just to understand more, you did the aortotomy, you go toward the non-coronary, then you go toward left atrium dome. This was initially your approach. You go towards the left atrium dome, then you have an opening like a book of aortic and mitral now in front of you. You did the posterior, so now the anterior mitral. On what, the suture on the, suppose the anterior mitral leaflet, that one, I don't understand the anterior, what was the material used to put the suture at that area?
Look at this video here.
Okay.
Yeah. When you remove this mitral prosthesis, you still have the annulus, but it is separated from the annulus of the aortic valve. So you have tissue here. You have a good tissue here, on which you just a new prosthesis. You just remove this one, put a new prosthesis, but you need to close this gap. So the sutures of, do you see the cursor?
Now I see it, yes.
Yeah. So you put your mitral set of sutures like usual here, and on top of another set of sutures, but instead of exiting in the left atrium, you go through the cavity and exit here in the annulus.
Okay. Tricus in the annulus of aortic valve. Okay.
So that there are 3 or 4 of them. You use them, and then you complete your set of sutures from the annulus of the aortic valve like normal.
Okay.
So and then you have this cavity. You open it to the pericardial space. It's already open.
Yes.
So if there is any abscess in the future, you drain it to the pericardial space. But now it is open between the aorta, ascending aorta, and the roof of the left atrium. The roof
now
you can see the roof of the left atrium is away. It's pushed away by this cavity.
Yes. Now I understand why you did this technique. Now it's clear.
Yeah. And now the dome here is open to the pericardial cavity. And of course, you open it, you want to see that, you make sure there is no bleeding, your obliteration is tight. If you have a bleeding, it will be a problem. So you open it to your hemostasis, your repair here is excellent. And also to train whatever thing that can accumulate in the future. So we left that open to the pericardial space. And it worked. So this is the thing that we got on follow-up.
What's that shadow in them behind the mitral?
Yeah, this is in the line of shadowing of the mitral. I think this is an artifact of the leaflet. Just a shadow, the shadow of the leaflet movement. It's a normal thing. This tilting thing in the shadowing of the mitral, right?
Yes, I think because of the mechanical, this one.
You are referring to this one?
Yes.
So yeah, this is the shadowing from the mitral leaflet. It's moving the same like the mitral process. The non-coronary sinus, very frequent to get endocarditis with involving of non-coronary sinus causing either pseudoaneurysm or fistula. So another case of Bruxelles endocarditis, the aortic root, it was bicuspid, but you can see here a flow in the non-coronary sinus and a defect in the non-coronary sinus joining this cavity here. So this used to be an abscess cavity, which is now, once there is no abscess, it becomes a pseudoaneurysm. You can see it here without the color. So that's the thing. This is a non-coronary opposite to the interatrial septum, and the defect is here. So in this case, you need to drain this, at the same time address it from the left side. So you have to replace this sinus or patch the defect depending on how much defect you have after debridement. You go in, debride the edges of this. Either you patch it or change the whole sinus. So that's the options you have. Clear the pathology here and what needs to be done technically?
Yes. Severe seams.
Once you patch the defect, doctor, we have a redundant space or cavity. Do you like obliterate the space? And if you do, what is the technique?
So the recommendation is to drain these spaces. Just open it to the exterior, to the pericardial space. So this is aortic root pathology. Usually it will be bulging outside. So just put like dissecting for root replacement and make that open to the exterior.
Yes,
so
clear.
You will know that you repaired nicely, no bleeding coming from it. And also in future infection, if there is anything, it will not.
It will drain outside, yeah.
Outside. So that patient required a sinus replacement and replacement of the aortic valve. It was bicuspid and infected. The question of what type of prosthesis you use, again, this is a difficult problem in infective endocarditis, what prosthesis you use in terms of valves and in terms of changing the aortic root using Dacron versus biological conduit. This is difficult, but remember, if you use a mechanical valve in the setting of infective endocarditis, the post-operative management can be complicated because you have to anticoagulate these patients. If they have a stroke, they can bleed in their stroke. It's very difficult, but still, I think it is the mechanical valve is preferred in a young patient who has infective endocarditis, and he doesn't have a cerebral problem. You can place a prosthetic valve. Homografts in young patients, homografts resist infection by observational studies like this one by McGiffin. They resist infection, especially in the early period. Recurrence of endocarditis is less with homograft. But repeat surgery is in these patients is a nightmare. Homografts are not widely available. If available, they can be preferred in a patient in whom you think he will not come back for a redo surgery. But the exercise of mechanical versus tissue is the same like any valve replacement, like we discussed before for the tricuspid valve. So let's go. If there's no question, we can go back to our patient.
Yes, please.
Yeah. So our patient is a young lady who was referred to us after several weeks of documented MRSA endocarditis. And she had vegetation, mobile vegetation more than 2 centimeters on the mitral valve. and she had showers to her brain without neurological deficit or major stroke. The patient is non-ambulatory, has bed sores, debilitated because of advanced rheumatoid arthritis. Her mitral valve has moderate regurgitations. Other valves are okay. So what do you think we should do for this patient? This patient was not operated yet, and we are still thinking about her.
As indication of surgery, she is MRSA positive. That's strong organism, and
Okay.
and the other indication for her, she is not in heart failure, but there is showering to the brain.
Yes.
And she is not stroke yet. So these two make her candidate for or the surgery indication.
And
so
the large vegetation. Yeah.
And what?
The large vegetation on the anterior leaflet as well.
Yes.
Okay, but that size of vegetation is not strong indication to take her for surgery. Persistent sepsis, despite antibiotic, is indication, but persistent vegetation with antibiotic, it's not strong indication to take her to surgery. We need to elaborate more for if she will tolerate surgery or not, this lady, because she is rheumatoid arthritis. I don't know, there is question mark on immunocompromised. If she is on any strong medication, make her immunocompromised, and she's young to be bed-bound or immobile because of the rheumatoid arthritis. So we have to evaluate her more if she will be fit for surgery or not. If she is fit for surgery and the CT brain showing less than 1 centimeter of stroke, and already I don't know how many days she is post-stroke.
No, there is no stroke. They found they said that in CT scan there is a small showers, which is in cases when you do MRI. 4 weeks. And she
4 weeks.
In the case 4 weeks, she's on IV antibiotic, MRSA class 1, vegetation class 2B. But the problem actually with her is she fit for surgery or not? She has an indication to go for surgery. But now the question is the time of surgery. She has a class 1 indication because of the organism, and 2B for the large vegetation. So we want to not to have a large stroke on her because of this 2 centimeter vegetation. The question is, the problem in guideline, when I read it, it's like in the cases of all guidelines, there is about her, I need to see her physically to decide if she can tolerate surgery or not. If she is, and she agreed for high-risk surgery, we need to do surgery for her. And the bed sores, is it infected or not? If it is not infected, she needs to go for high-risk surgery.
Very good point, Hassan. I think this is very sensible discussion from all of you, very sensible. You just, in a case like this, you want to fit the patient into the guidelines. At the same time, you want to risk stratify the patient.
Yes.
And know your objectives of treatment. So first of all, she doesn't have congestive heart failure. That was raised, I think, by Uthman. No congestive heart failure, no severe valve lesions that needs to be fixed. So the only objective here, and also there is no active sepsis. It sounds antibiotics are working. So the only objective here is to prevent embolization and stroke, which having a vegetation of 2 centimeters on the anterior mitral leaflet in the setting of previous showering, but asymptomatic showering, makes her likely to go for surgery. But then you have to balance the risk with the benefit. The vegetations usually embolize in the early days of antibiotic starting. So
Yeah,
this patient, they go like maybe 4 weeks or more with endocarditis, and she's been or more than 4 weeks on antibiotics and did not embolize. Will it embolize again? Nobody's know, but the period of high risk of embolization has passed. The second
Two
point,
weeks.
yeah, exactly, 2 weeks, within 2 weeks. And now the point of Dr. Haytham in terms of risk, if you have focus of infection elsewhere in the body, like bed sore, especially with a notorious organism like MRSA, I think it's very hard to decontaminate this patient and prevent further bacteremia because the source is there and it's very difficult to treat bed sores when they are infected. So there is a very high risk of having recurrent infective endocarditis in this patient. It's very difficult, but at least she's not class 1A that you have to take her. And because the objective of treatment will not be met by surgery alone, we are not sure if we will need the objective of surgery or preventing further embolization. What I'm thinking is just to observe that you not get recurrence of infection, bacteremia, fever, leukocytosis, make sure the antibiotics are really working, inflammatory markers, and culture the bed sore. If the bed sore at any point is healing and is culture negative, then might reduce the risk of recurrent endocarditis if you go to surgery. And also having an unambulatory patient, there comes the ethical issue. If you really need to go for surgery for somebody who is not active in life, not because of the pathology you are treating, because of some other pathology. It's a very difficult case, but I like the way you discussed and trying to fit it into the guidelines and the way of thinking.
And Dr. Nadir, do you think MRSA alone in other patient, a strong indication to take her for surgery?
Yes. Staph aureus of any kind, MRSA, fungi, they make the patient surgical. But of course,
the question, when the best time to take this patient? If there is no other indication, only Staph aureus infection, the best time to take this patient?
Once you establish the indication for surgery that will do the objective, you just go ahead once they are fully marinated with antibiotics. So a week of antibiotics should be enough. If there is an established indication for surgery, you just
Thank you, Doctor.
So we are done.
Thank you very much. Tafadhal, Hussein.
Last question. How do you deal with the patient with mycotic aneurysm? You treat them as stroke or you treat them as hemorrhagic?
If there are complicated rupture, then the patient is in bad shape. He has a hemorrhagic stroke already. This you cannot take them right away. So you need the help of your colleagues, neuro intervention. If they are already diagnosed with mycotic aneurysm, they should better be embolized before or coiled before going to surgery. If they already bleed, this patient you are not going to take him for surgery right away. They have to go through neuro intervention procedures. And if they cannot do anything, then you should wait at least for 4 to 6 weeks before you reassess and decide again for surgery.
Can we do coiling for mycotic aneurysm? That will not increase the risk of infection?
I cannot answer that question, but they do. They do coil them, they do clip them. They do different things that I don't understand, honestly. But they did help us with a couple of cases that had mycotic aneurysms and they fix them before they go to surgery. And unfortunately, one patient ruptured his mycotic aneurysm before surgery, and we had to do him like 8 weeks after that. But they are very good. They understand it very well, and they have the techniques.
Thank you.
Thank you.
Doctor, one more question. If a patient with endocarditis developed like a recent stroke within 1 day, we don't know the consequences because the patient is intubated. She has a significant, let's say, mitral regurg, going into heart failure. Is there a window to take her like within 1 or 2 days before it becomes hemorrhagic? I mean, the stroke that the ischemic stroke that she had, which was most likely from the vegetations.
So if the patient has an established indication, class 1A indication for surgery because of
Yes,
and he strokes,
exactly. Yes, that's the question. Yes.
Wait for at least 2 weeks and make sure he's awake. Don't take a patient in coma to the OR. You're not making him better.
Okay, fair enough.
Coma should be excluded. Major stroke, wait for 4 weeks at least. Minor stroke, 2 weeks if there is a class 1 indication for surgery.
Clear. Yes.
Thank you, Dr. Nazeer. Any other question? Because I have a question outside these two topics. Anyone have another question in tricuspid or infective endocarditis? Okay. Kindly, Dr. Nazeer, regarding patient with MAC in mitral valve replacement or mitral valve repair, what's the surgical technique if you, we read it, but we need kindly your elaboration. We read that either you do debridement, supraannular, you put the valve supraannular, intraannular, subannular. What is the best things if I was faced with a patient with severe MAC? Of course, I would not, for me personally, I will either I don't have the expertise to do that. I will ask my senior colleagues to do the case. But what is the principle we have to do in cases of severe MAC?
Yes, so MAC is a difficult pathology, especially in the mitral. It does increase the risk of a stroke. There are technical difficulties with dealing with MAC valve replacement. I'll tell you what I did with the cases I have faced. Usually the MAC involves the posterior mitral annulus, the C-shape
Yes.
for one or the other, I don't know, but it does involve the posterior annulus. So if I decide to take the patient for surgery after telling him the risk of stroke and difficulties and risk of major bleeding intraoperatively, risk of on-table death, that should all be explained. So you are not going to excise the anterior mitral leaflet. First case I faced, I just put the needle through that calcium. Not all calcium is very strong. So try to find a place where the needle goes while maintaining the endothelial covering, not exposing the calcium. If the needle goes, you can safely place the matrix sutures over the calcium on top of the endothelium. That can succeed in some cases. But you should not leave gaps. If you are going to leave gaps, that will not work. So it worked with me with a couple of cases. One case, I tried to do this and it was not possible. It was very tough calcium. So what I did, I excised the anterior mitral leaflet, put the matrix sutures as usual on the anterior annulus, and the rest of the sutures, I placed them atrially in the posterior leaflet. So the valve is inserted, but somewhat tilted, and the calcium was covered well respected inside the annulus of the trachea of the mitral valve. Of course, if it is just a focal calcification, not very deep, you can open it and enucleate it. And then just if reconstruction is needed, then you have to put a patch. If not needed, then you can, by the matrix sutures, you can occlude the defect that's created after enucleation of the calcium. This is too aggressive. Only people like carpenters, they do. Now, if you think it's technically difficult, sometimes I've seen a case with calcium extending from endocardium to the epicardium, through and through. These are very difficult cases. There are percutaneous now alternatives to mitral valve replacement that might help in MAC cases, MAC mitral cases.
Thank you.
Okay. Did I answer your question, Haitham?
Yes.
Always think of alternatives if the patient is difficult. Great.
Any further question from the group?
الله يعطيكم العافية.
Thank you. شكرا دكتور.
شكرا يا شباب، شكرا جزيلا. تعلمنا من نذاكر. شكرا.
لا الله يعطيك العافية أستاذنا، الله يخليك. ألف شكر وتسلم ويعطيك ألف عافية يا رب.
بالتوفيق.
ما قصرت، الله يعطيك العافية يا رب.
الله يخليك ما شاء الله.